I am an assistant professor right now in the Department of Radiology at Stanford, and I traveled yesterday from California, which means for me right now it's about 6 a.m. and I didn't sleep the entire night. So as such, I hope I can keep you awake as well as myself as I present my research. A couple of things that I wanted to mention about myself and a little bit my career. I have been away from Romania for more time than I have actually lived in Romania. So it's about 21 years since I left. I did everything after high school in terms of training outside of Romania. As such, I also have pivoted very much during my career, which I translate a little bit. It's a pivot is a term that it's used very often nowadays in startups. In my context, it meant that I did a PhD in a very different field that I currently study, so that's possible. I also work in industry for a little bit before joining Stanford. I work as a medical image analysis scientist at General Electric Global Research. This is in upstate New York. So I've been living in the United States for about 16 years now. And in the last 5, I've been in California, specifically at Stanford, where I lead a team of scientists. I work very closely in collaboration with clinicians, and today my talk is very, very much at the border between the two of the fields, right? Between the medical field and kind of also the technical field. As such, I like to also disclose some of my affiliations. I am a consultant for Roche, and I also have grant research money from Philips Healthcare, but none of those are relevant for the discussion today. So I want to start by telling you about the mission of my lab, and my research has been to develop methods to improve the interpretation of radiology images. I have a technical background. I am not a clinician. And as such, in this context, I do develop a series of methods. Some are focused on localizing and doing subtyping of diseases. Specifically, I work very often on cancers. But then I do this, and I apply these methods after lengthy pre-processing, and it was mentioned already what we mean by pre-processing. But one of them is that I want to know exactly where cancer is, and I do that in collaboration of using the pathology data, as was mentioned, and specifically, I am looking to integrate the radiology and pathology images through registration, but I do that for labeling, so I want the best label I can get for where cancer is on a radiology image. And then finally, I do the classic things that we all need, which is organ segmentation or different type of other more basic AI tasks. But ultimately, the goal is to be able to improve the interpretation of radiology images and using multimodal data and multimodal machine learning. And today, I'll talk a lot about prostate, but my team does a lot more than just prostate. We do kidney, breast, and brain as well. But why are we looking at prostate? So we are looking at prostate because it remains the most diagnosed cancer in American men. About 20% of all cancers are of the prostate, and still the second deadliest one, about 10% of all cancers. So it's still very common. And I like to show this example of the clinical workflow. Usually I call him Mr. Smith, but today he's going to be Mr. Ionescu. And as such, this patient will go through the screening pipeline, which in the United States involves taking a prostate-specific antigen test, and in combination with the digital rectal exam. If there is suspicion of any of them being abnormal, then the patient will probably go through a process of being diagnosed, to the process of searching for the diagnosis of cancer. Usually that is done through the use of a biopsy, that is performed under the assistance of ultrasound. So it's an ultrasound-guided biopsy, and if the patient is lucky enough to be in one of these universities or in one of these hospitals that actually does ultrasound MRI-guided biopsy, the MRI will be used in order to drive that biopsy needle. And I'll show you in a few seconds why we care about that. But this is the pathology image that we get from the biopsy. And then if this patient, Mr. Ionescu, will actually have cancer, cancer, the patient will be sent to get some form of treatment, and one of them is radical prostatectomy, where the prostate gets removed from the body. From my perspective, this is the best data that I can get, because now this entire organ is being pushed in pathology. And at pathology, we're going to see in a few slides how nicely you can actually see where the cancer is, and a lot better than the radiology image. But ultimately, the reason why I do all the things that I do is because prostate MRI remains the modality that shows the best the cancer, at least before that organ goes outside. So it's being used more and more to guide the biopsy procedure, as well as local treatment. So there are a series of treatments that are not as radical as removing the prostate, that are more local. If you know that the cancer is present in a certain location, now you can do and apply something like focal ablation. So essentially send a lot of very hot air, not air, but it's essentially burned or cryogenic, so it's being frozen. But there are a couple of treatments that can be very localized, which is very good because the recovery is very fast and success rate is pretty good. But there are problems with interpreting any radiology images, and in the cases of prostate MRI, some cancers are still missed, depending on which population you are looking at. At minimum, 12% of cancers are missed. These are important cancers. They are called clinically significant cancers. And along with it, radiologists tend to try to be on the side of caution, which means they will say certain things look suspicious, even if they have a little suspicion, because they want to make sure that they are not missing anything. Again, this is the American system. Everybody's scared of a lawsuit. So as such, there are certain decisions that are done in a medical setting that are essentially driven by this. From our perspective and the perspective of the patient, what it means that there are a lot of false positives. So essentially lesions that are kind of suspicious, but when they do the biopsy, they discover they're actually not cancer. And if you take multiple radiology and you ask them to interpret the same image, they might come back with different answers. When we evaluate kind of the extent of how well they agree, this kappa coefficient, which usually ranges between -1 and 1, with 0 being no agreement at all, and 1 being where they perfectly agree, the kappa coefficient is usually between 0.46 to 0.78. So it's relatively low when you look at how well these radiologists agree with each other. So the goal of my team is to develop these AI methods that are able to help radiologists interpret their images, reduce the false positives, because every false positive of radiologists means another 3 needles in a prostate of a patient, and then decrease this inter-reader variability that I talked about. And ultimately, what we do want to help the radiologist and then the actual urologist that drives that biopsy procedure is to be able to guide the needle towards the region of the prostate where there is aggressive cancer. And if you may know about tumors, they tend to be very heterogeneous. In other words, there is always a mix of aggressive and indolent cancer. So some parts are more aggressive, some parts are less aggressive. But ultimately, you want to really find the part that is aggressive, because then you actually are going to do something from a clinical perspective to help that patient get rid of this cancer quicker. One of the main focuses of the research that I've done in the last few years has been to automatically distinguish this aggressive and indolent prostate cancer. And what we do different from other people is that we're trying to do this on a pixel level, so really within the image. So how I do that, as I mentioned, is through bringing the pathology. So why do I bring the pathology? Why is this so important? So as I said, this patient gets a radical prostatectomy. Those are the patients that I like to focus on. And then for these patients, generally I have an MRI that was acquired before the surgery. And then the surgery will remove the organ. The organ gets sent to the pathology, and it gets nicely sliced, and then we can see this nice image here. What I'm showing here in red and blue are the extent of aggressive and indolent cancer that has been outlined by a pathologist. I'll go a little bit more in details in a second. But one of the first things that I want to do is take that pathology and put it back on the radiology image, so I know exactly where that outline of the pathology fits relative to the MRI image. And I like to do that because I have all these labels of clinically significant cancer and indolent cancer. That means the one that is not going to kill the patient. But I also get a lot more. One of the things that the radiologists are looking for, or the clinician actually is looking for, is to understand whether this cancer actually has gone outside the prostate. In other words, it's called extraprostatic extension, which is a sign that this is another sign that this cancer is very, very aggressive. So it's through the surgery, we know that this extraprostatic extension can still be removed at the time of the surgery if the surgeon knows that they need to remove a little more. But they tend to again, be kind of preserving as much as possible the anatomy of however is removed. So there is always that balance between leaving this cancer within the patient or not. Leaving the cancer in the patient is a bad idea. That usually results in biochemical recurrence and later metastasis, which is not at all good. So we like these labels from the pathology side because we get all this level of details, but more recently, we have started to tap essentially in what Bart mentioned, which is the idea that you can actually apply AI on pathology images. And while my team has never focused on developing these methods, we are actually using methods that have been developed by others. There are people that have been spending years now, maybe more than 10, 20 years, developing these AI methods for pathology data. Then I'm not going to waste my time in order to do that. So we are all users of digital pathology. An AI solution for pathology, and more specifically, we like to call, and as we're labeling and we're trying to assign names, we actually call this the digital pathologist. So an AI solution for a pathology data, we call that a digital pathologist, and we want to clearly indicate that this is not the human. But here I have an example of what do we get in addition now from the digital pathologist. This is a little bit of a busy slide with a lot of outlines, so I'll go one by one through it. But what I want to show here are a couple of things. So we have a very, very patient pathologist. Unfortunately, he decided to leave Stanford, so we don't have anymore a very patient pathologist, but we used to have one that is very patient, and he has gone an outline, and you can see the black outline in this image. You can see it kind of on this edge. Let me see. Do you actually see my mouse? Maybe? No, you don't see my mouse. Let's see if I can get you to see my mouse. Here we go. Okay, now I see my mouse. All right, so if we look at this edge here, it's a little hard to see, but on this edge here, in black, there is an actual black outline. It's a bit hard to see. But we can see very well so what is outlined in black is essentially our pathologist saying this is cancer. And what's outlined in yellow, it's our pathologist saying this is Gleason score 3+3. So that means a cancer that is indolent. And what you see in orange, our pathologist went and said this is 3+4. This is a little indolent, but with a little, and he says some 4 means aggressive. So it's a little bit with 4, but so it's a little aggressive or a little amount of aggressive cancer. And then the same, the pathology says in red, that's again 3+4, so it's a little bit indolent, but a lot of 4, or a lot more 4, so that means a lot more aggressive cancer. But now what we see in blue and green, those are actually the detections of the AI approach that I'm using for this particular slice. And what we see is that the AI solution that we use to analyze these images agrees quite well with the pathologist, with the difference that not at the same resolution. So a digital pathologist will go ahead and will not be tired to look at these images that are 80,000 by 80,000 pixels and will go and outline. We'll go and outline every single gland that we see inside these images. I see it, okay. So as you can see, they go and essentially the AI solution will annotate everything, and I also have pixel level extent of where the disease is present. So going back, so in other words, there is a reason why we want to use the digital pathologist annotations, just because we get a lot more detail with a lot less effort. So then that's kind of the idea that we had as we are going into this. So kind of summarizing, So we want to use the pathology labels, and so why not the radiologist? Well, we said the radiologist is missing the lesions sometimes. We also said they have false positives, but also there are some cancers that are very well known, and they are called MRI invisible, and I like to have a second category that is called MRI hardly visible, which means when we show this image to the radiologist, still have. Okay, maybe I'm not seeing all the red. Okay, here we go. So when I show this image to the radiologist, they only saw this region here that is outlined in yellow, saying that, okay, this is a suspicious region. Now, this is actually how the cancer looks like when I project it from pathology. So what do we see? Well, first of all, the cancer is a lot bigger than what we see that the radiologist thought. It also has a very different shape compared to what the radiologist thought there is cancer. Second of all, we have a cancer that was missed, which is this one. That's not a big problem in big scheme for this patient because this patient had a radical prostatectomy, so the entire prostate went outside. So it doesn't matter that there is one or two. It mattered that they found one to start with. So, but for the purpose of if this patient wanted to do local treatment, this patient wouldn't be eligible because having cancer on both sides of the prostate essentially disqualify you from using this type of procedure. So anyway, in this context, we are using pathology labels and then doing all the things that we need to do in order to be able to use them. So let me tell you about the things that we actually do. So I said we are focusing on organ segmentation. Specifically, we're doing prostate segmentation. We are focusing on labeling, and I'm going to talk about the training of the AI model to do the cancer detection. So a lot of slides or a lot of our work has been to develop these methods that generalize. So this is a method developed by a PhD student in my team. When he was in my team, he was only an intern staying for a short period of time. But what he has managed to do is to train, and he's a medical doctor, currently a PhD student, be able to train a model that is based on a simple UNet. This is a network that is very well known in the medical space that essentially takes as an input an image and outputs a region that we have of interest. In this particular case, we use the prostate. And based on kind of how our standard of care works at Stanford, this segmentations are being used by the urologist in the process of guiding the biopsy. So I said that there is MRI fusion with the ultrasound. The fusion is done based on the segmentations. So essentially, we can see that the deep learning method, the yellow outline, is actually as good or almost as good as the urologist expert. This is the clinician that we are working with compared to a radiology technologist. And these radiology technologists, so they are essentially they are folks without clinical training that are helping this process by going ahead and segmenting the prostate. They can take about 30 minutes to do that prostate segmentation. But ultimately, before it goes in the patient, the urologist will actually double check that the prostate is properly segmented. So we compare it with the technician, and we show that we are actually better than the technician and closer to the expert in segmenting this outline. The most recent work that has been accepted from my team is focus on segmenting the prostate on ultrasound. Again, we need a prostate segmentation on MRI, and we also need it in the context of the ultrasound. This is a lot more challenging problem because the signal of an ultrasound, it lasts less than the one on the MRI. In other words, we don't see as well the prostate. And this particular work, driven by Suleiman Vesal, he's an engineer in my team, has been focused not only on developing these models on Stanford data, but actually looking at how this works with external data, how to make sure that we can actually easily bring external data and essentially train with a small number of cases in new institution and be able to achieve similar accuracies as we are getting from our institution. So this is a pretty long study, and we have data from Stanford, UCLA, and then also from UCL, so University College London. So we are starting to also move across the pond, so to speak, in order to get data. Their data is so much different from what we see in the United States. So actually, it's a very good example of how how to try to get these AI models to train very well. So we obtained very good accuracies. We are excited about this model, and our interest is now slowly focusing towards the ultrasound side. But today I'm talking more about the part that is relevant to the MRI work. So I did mention that a lot of the work that I do is focused on registering or aligning this radiology with pathology images. This is very challenging and has been done for many years. I think I'm definitely not the first person to come up with this idea of lining the data. But in this particular work that I called Rhapsody, Radiology Pathology Open Source Multidimensional Integration Platform, what Rhapsody does, it's essentially assuming there is a slice-to-slice correspondence between the radiology and pathology image. We can make that assumption because every patient that undergoes a radical prostatectomy at Stanford actually gets this 3D printed mold that allows the sectioning of the pathology tissue in the same space as the MRI. And with that, we can essentially reconstruct that object that was removed from the patient and project it back onto the radiology image and get our labels. And I'll show you later, we don't only want the labels, we want more than just that. But we can reconstruct that pathology in 3 dimensions, and definitely we can look and see how those labels actually project in 3D. So it's very satisfying to actually see some of this overlays. And I think if you make the light a little dimmer, you were going to start seeing it a little better. You can see the pathology kind of starting to come onto the MRI, and it's going to leave the labels and then kind of leave from the MRI. Again, it's very interesting to look at the pathology and see what the MRI captures with that. What we have managed to do is that we have taken this approach that is the Rhapsody, which is actually based on an iterative approach that classical registration methods are doing. We have developed a deep learning version of it because we wanted to speed it up, and also we wanted to see if deep learning can do as good. We were like, okay, let's see, maybe it does even better than the general approach that we used before. And it's very interesting how you go from trying to take a traditional image processing approach into the deep learning space. And in this particular context, we of course needed training data, and we used traditional or natural images. In this context, we use a data set called Pascal, and we also use pathology images, we also use MRI images, and we artificially created this transformation into the data. We have seen a little bit, Bart has shown how we rotate the images. Well, that's what we did. We essentially rotate and translate and say, okay, can the deep learning actually recover that transformation, essentially be able to identify the transformation that we have applied. What we have shown with the deep learning approach is that while it was only trained on Stanford data, this was very generalizable outside the space of the data that was trained at Stanford. And then we have showed here in cohort 2 and 3, these are public data sets, both coming from the Cancer Imaging Archive, which is a very relevant resource in the United States. I think it's available to be used outside, that has this tremendous amount of data on radiology images very often, but now they have cohorts with radiology and pathology. This particular data sets are very valuable for our analysis, but we've shown that we can align this data even if we don't use it in our training data, and we can project those labels. And we showed that while the measures that we tend to use are quite similar between the traditional approach and the deep learning approach, which is not surprising, the part that actually becomes very relevant is the speed up. The fact that the deep learning approaches are able to run this in seconds compared to the traditional approaches that are more like minutes. And also the fact that once you train a deep learning method, there is very little setup that you need to do. As we saw earlier today, you can load that model in one line and apply it in another, and you're done. Whereas with the registration methods, it's not as simple. It still requires quite a lot of fiddling with the parameters. I like to make this table summarizing because actually my team has done a lot more work in this space of aligning the data. I think in the interest of time today, I'm not going to talk about all of this. I can talk for many hours about the research that we are doing. But point being that we have took this to the next step in actually looking at when you don't have that slice-to-slice correspondence that we talked about, how do you actually take advantage of the generative adversarial network to identify and extract the information or enhance the information that you have in these images to be able to align them better, and also start looking at methods that are weakly supervised, that don't have as many requirements on the labeling as we initially wanted. But the work that is called Rhapsody and deep learning-based Rhapsody are kind of like the ones that are setting the stage. But I do want to have enough time for questions, and I want to also show exactly what we do with this approaches. So the thing that we have done specifically different than other people is the fact that we had and we have processed enough of this data to actually be able to train deep learning methods. Many people, as I said, have registered radiology and pathology in the space of the prostate, but they do it as a proof of concept with like 10, 20 cases. That's definitely not enough to train a machine learning. We have done it in 150, and we are doing it even furthermore in more data as we proceed with time. But the first step that we wanted to take down were like, okay, we have labels, we have this digital pathologies labels, let's go for it. Let's see what an AI approach can do with these labels. So the first network that we have trained, we call SPCNet, stands for Stanford Prostate Cancer Network. It's based on a holistic nested edge detector. So it looks at a variety of it has a variety of layers, a variety of resolutions, and the side connections in order to be able to extract as much information from two of the sequences that are more important for the prostate. One is the T2-weighted MRI, which shows the anatomy of the prostate, and the other one is the appearance diffusion coefficient, which shows how the water diffuses. That's actually the very important one because it shows cancer better than the anatomic image. And then with that, those two images as an input and the labels coming from the pathology, now we can set up our network and see how can we actually, how well can we start predicting the extent of aggressive and indolent. So we are starting to see that, like, for instance, we see the ground truth here shown in yellow and green, and then the red and blue are the ones that are our predictions. And we can see that the cancer is very well detected. We're still looking and working towards actually be able to distinguish between the subtypes, the aggressive part and the indolent part, but we are getting there very, very closely to that. So one of the things that now we have started realizing is that not only that we have the labels where cancer is, we actually know the pixel. We know the pathology image and the appearance of the pathology image at that location where we say there is cancer in the MRI image because they are spatially registered, right? That's the whole goal of applying these methods. So then we devise an approach that essentially is learning what we call MRI signatures of cancer by looking at what features in the radiology space correlate with what features in the pathology space. So we essentially push these images in what Bart mentioned earlier today, the VGG16. The VGG16 network is extracting these very basic features, if you want, of that image. We saw edges and we saw, and then we combine those in a step that is called correlated feature learning, in which we learn how to combine radiology features such that they correlate with a combination of pathology features. This is what the CoreNet network does. And when we learn that information, now we can specifically look, for instance, at how these features look like. And I also like to show some of the features because I think it's me. Okay, here we go. So we can actually see the different kind of edges at the different directions, and we can see the same ADC features, so feature extracted from the ADC images, and we can see the pathology ones. And then when we combine them, what they essentially do, they're starting to show an emphasis of where the cancer is in this image, which is at this location here. So we can see it a little clearer. And then similarly, as I said, when we are identifying what we call the correlate MRI features, the MRI signature, they correlate with the histopathology feature. So they essentially, we are creating textures on the radiology image only that correlate with the pathology. And we do that in this fashion because what we want to do is to extend our networks to combine the signatures. So we have this MRI signatures that go now as an input in addition to the T2 and ADC. and they provide additional information because they have the pathology. The reason why we do this in the way we do it in a two-step approach is because we don't want to need the pathology at the time of the inference. Because at the time of the inference, if I ask for my network to use the pathology, that means that patient has to have the prostate already removed. If the prostate is already removed, it's too late. We can't do anything about it. So the whole point here is that I want to learn from the patients that have pathology, but ultimately I want to be able to apply my model in a context where pathology is not present, because I want to use this prediction to drive the needle of the biopsy, and I want to use this prediction to be able to drive the essentially the local treatments. So with that, we have shown that we are able to do better than we are doing just using the simple, what's in quotes, labels that we get from pathology alone. And then Corsignia, which is this approach, is able to detect better those regions that are aggressive and indolent. And we compare it with a variety of methods, and we are looking at like the famous UNET, and we are showing that it always outperforms. But overall, it actually ranks better than the other approaches, and is able to have a specificity of about 0.87, a sensitivity of 0.7, so and an accuracy of about 0.8. This is still maybe not good enough yet for a patient, but we're getting closer for being able. Definitely, we can do more than the radiology does. But I think we need a lot more data to be able to say, okay, this is ready, this is patient ready. But it does show how we can do this and how we can use this. And it did give us an opportunity now to also start looking at how well the radiologist and pathologist compare to each other. This is a study that the radiologists don't usually like to hear, and especially more so because we are looking at how well they overlap. So we look at all the measures that we use to assess how our methods work, like how all the computational methods work relative to the ground truth, and now we apply them and compare the radiologist with what we call the ground truth, which is the pathologist. I stop there for a second just because the pathology is not perfect either. But that's a very different discussion. We can probably have a different lecture only about that. But particularly in this context here, we always look at dice coefficient, and dice coefficients are ways of assessing how well two objects overlap. So if you have a dice of 1, they overlap perfectly. If you have a dice of 0, there is no overlap. So if I compare how well the outline of cancer by a radiologist overlaps with the outline of cancer from a pathologist, that is 0.24. That's very low from my perspective. If our methods show 0.24 in dice, they are usually, oh, your method works very badly. And but we understand the limitation of these metrics as well. So when we look now, and it goes back a little bit to the standard clinical care, the amount of overlap for a clinician is not as important as it is how many lesions did pathology found that radiologists found. So essentially, it's more of a lesion level assessment, less of a how much of it did I find, which is what I measure with the dice coefficient. So those numbers are a lot higher. So about 75% of, comparing the radiologist and pathologist, we can see that we have essentially an overlap, an AUC of 0.75, which is what I'm seeing. I'm talking about this number here. This is the AUC of a radiologist relative to the pathologist, and the 0.24 that I mentioned is this. Now, we compare a multitude of similar or different labels, right? I mentioned the radiologist, we call them LRAD, the pathologist, so this is the pathologist. And then we have the digital pathologist, and we have two versions of the digital pathologist because we want to be able to look at pixel level. So we look at pixel and lesion. Ultimately, this is like a confusion matrix, but for labels. Ultimately, because we had all this beautiful data, we also said, okay, let's let these models train with different labels, same data, different labels. Let's see what are the advantages of doing one versus the other, right? So if we have a radiologist labels being used, how many of the lesions we find? This is what happens when we train with the radiologist labels. This is the ground truth from the radiologist, and this is what the prediction looks like. Then with the pathologist, This is the ground truth, and I'm going to talk a little bit about this one, and this is the prediction. We don't see a label here, and what happened in this image, this particular image, the radiologist, I think, was probably busy on that day and didn't label this image. We still have it in our data set because that person has labeled other images in that cohort or in that patient. So when we have to make some decisions with how we train these models, and we wanted to just have that as an example of what happens when, real data essentially happens. And then similarly, now we have the digital pathologist. As I said, the AI methods are never tired, so I get all these details, and then if I look on a per pixel basis, it looks like this, an aggressive and indolent with green and aggressive with yellow. If I look at it and think about it as more of a lesion, is the entire lesion aggressive? Then I see this version here that is the second to last column. So point being is that now, while we do tend to be kind of a little critical of radiologist labels, the region in itself gets predicted, irrespective of which labels we use, with the advantage that if we use the ones that we have pixel level annotations of aggressive and indolent, we are closer to the actual ground truth in finding and being able to distinguish the two. And I think that's a kind of an important point there. And kind of this is what these tables are summarizing. I summarize it more in words, but point being that we want to use these labels from the digital pathologist. We want to also be very careful how we use them. It's a lot of data with a lot more errors as well, because now we have all the errors, the AI error in the pathology, the registration error. There are a number of things that can happen, and we are working on improving the different aspects. But ultimately, again, I like to create these tables that kind of summarize the different approaches and kind of how we see the advantage of one or the other. And finally, this is the last piece of research that I want to talk about and leave enough time for question, is work done by Stefania. Stefania is a PhD student in applied physics, where we started tackling the problem, can we actually predict whether this cancer goes outside the prostate? Usually when it goes outside, there could be different amounts of the cancer going outside, and sometimes it's called gross extraprostatic extension, which means it's really, really big. But more often than not, it's actually just a couple of pixels relative to the radiology image. So we wanted to say, is there a difference in these cancers that are going to go outside? And currently, the current practice is to say, well, if that cancer comes very close to the border, and not only that is close, but it's also very much goes kind of on the outline of the prostate, it's more likely to go outside, of course, because it's so close and so much pushing the boundary that is more likely to go outside. So clinically right now, how people are looking at this is to essentially measure how much it touches the border of the prostate. And if it's around 2 centimeters, then radiologists will say there is a suspicion that there is extraprostatic extension. So what Stefania has done is to take a model that we have essentially trained within the prostate and apply it outside the prostate. So it's still cancer, it's still the same image, just that we normally train inside. We apply it and then see if we can distinguish those cancers that are able to essentially go outside the prostate. And we can see here a couple of examples of how small. This is a cancer. This is the same patient that we see. And then we have multiple slices kind of as we're going through the MRI. And then we can see that there is very little cancer. There are barely pixels that are visible on the different images. And then when we look at the predictions, we can actually see that the predictions are suggesting that there is something that is suspicious on the outside of the prostate. Of course, we're not yet at the accuracy that we would like, which is to be able to really pinpoint exactly what the extraprostatic extension is, but we still are starting to have indication from this model that we can essentially, that there are features that are different between these cancers that go outside and those that stay inside. And we look at the variety of approaches, and essentially the sensitivity of a radiologist is about 50% and a specificity of 76%. We have a better sensitivity, but a worse specificity. So I think work still is needed to be done with improving these models, but it already shows that we can get information that could be useful for the radiologist to look at. So kind of to conclude, we work on methods to segment organs. We work on methods to register radiology and pathology images to be able to label data that we later on use for distinguishing these aggressive and indolent cancers. And with that, I will thank you for your attention, and I will also thank all the people in my team that are working on this. We are always interested and I can talk to folks that are interested in postdocs. We are always interested in postdocs. We're currently hiring, but we have quite a large number of postdocs in the team, engineers, PhD students, master students, and we work very close collaboration with our clinician, the most important being Jeff Sun. He's the urologist that essentially helps us make all this possible, and he's right-hand Richard Fan from the urology department. And this is a recent picture of my team, a lunch where two of my folks were leaving the team, one going back to Sweden to finish a PhD, and the other one starting, my first postdoc has essentially started his faculty position. So I'm very excited to see him start his new lab as well. So different pictures there. And then finally, the funding agencies that make this all possible, including NIH funding, which is kind of the more important one from American Standards Research.